انشقاق الوعي. انشقاق الوعي أو
انشقاق الوعي
أو الانشقاقية.
في الاي سي دي، في طبعا الاي سي دي 10 مترجم للغه العربيه من قبل مركز WHO World Health Organization في مصر، والترجمه اللي استخدموها هي التفارق للديسوشيشن، لذلك انا استخدمتها في هذه الترجمه. وطبعا التفارق dissociation is really one manifestation of what is called complex trauma or complex PTSD or developmental trauma. There are many really terms to describe the complex trauma, and again I'm referring to Van der Kolk. Again, and I'm saying you should all read the book, The Body Keeps the Score, because there are 3 chapters on complex trauma that describes it in a wonderful, easy, and very evidence-based way. I mean, I met Van der Kolk in 2012 in an EMDR Europe conference in Madrid, and followed his research all the time since then. And then when his book came, he really summarized all the research. So all my hard work, I'm just really joking, but I could have saved all this hard work by just reading that book. So it's really a wonderful book, easily read, easily understand. What is your understanding of complex trauma? Anybody?
Ongoing trauma. Ongoing continuous trauma.
Okay, so ongoing trauma is one definition. The other?
That the client with the patient has had multiple traumas.
Okay.
To the extent that it's affecting their functioning, their relationships, and the way they handle stress, the way the consciousness. So they look a lot like borderline personality. So that's what I.
Yeah, one definition is repetitive, continuous traumas that usually have interpersonal nature, and it is associated a lot with childhood and abuse that children can really suffer, but it is not really restricted to that. People who go through, for example, continuous torture or continuous traumas of any description can also develop complex trauma, and it does affect people's perception, sort of self-perception, perception of the world, the meanings, the system of meanings of the people, of the world around them. This is really described beautifully by Van der Kolk in his book. So these clients are a challenge really to us, and they, as Van der Kolk said, really EMDR is very helpful too in these disorders, but probably we need to do something else also. And one of the things that we need to do is extended preparation, very important, and that's what I'm going to discuss. Sorry if I'm going to repeat some of the things that I said before, but it is very important really to set the ground for really the preparation and how we can use it in a way that helps both trauma, simple trauma, and complex trauma. But we will talk really more now extensively on complex trauma. So we are going to explore the importance of preparation during EMDR therapy, particularly for complex trauma. We examine the different methods, and we explore the different methods of how to really prepare our patients for processing, particularly in complex trauma. As you know, I mean, just really because we had the sad news this week of the death of Francine Shapiro, who I personally met in 2014. She attended the conference, EMDR Europe conference in Edinburgh, and I had the opportunity to meet her and talk to her, and There's a lovely picture that actually Professor Suad from Cairo University took, and she kindly sent me of me talking to her about my book, Arabic book on EMDR. She was very impressed and very kind and very generous in the way she perceived that. And I always remember how generous and encouraging and supportive. And actually, we were in a meeting, me and Osama, to discuss establishing last month to establish EMDR, Arabic EMDR Association with Munaza Groot, who is a Palestinian trainer who trained under Shapiro. She has very close relationship to her. And one of the things that Muna told us is that Shapiro said she will attend a meeting to inaugurate the Arab EMDR Association. Unfortunately, of course, that won't happen now. But as Caroline said earlier, the fact that we are working here under the umbrella of Trauma Aid UK is a testament to her work, because really from the beginning she started with what's called the Humanitarian Assistance Program, which then became the Trauma Aid programs, and really all the work that have been done in that regard. Really, I want to highlight that very important for all of us is to be guided by her really book. And I'm going to really quote her a lot in this presentation. I movement is traditionally processing basic principles, protocols, and procedures. Very important book really we should all use and refer to, because that is really the standard protocol that we all have to base our work on, and then develop other procedures. And what I'm going to do in terms of the preparation is really, as Shapiro herself in this book said, on page 131, the main aim of the preparation phase is to prepare the client for processing. And that's by establishing a safe and therapeutic relationship with the client. And that, as we discussed before, it starts from the first moment you meet the client, of course, and we discussed that in details. Then explaining in details the process that we are going through, the therapeutic process, and addressing any client queries, potential, and meeting any needs that the patient has. Very important in explaining the model of EMDR is to use the major theory that Francis Shapiro discovered, which is the adaptive information processing theory. And in this, a simple way of explaining it is that, as Shapiro herself put in the book, is that we can explain to the patient that the traumatic memory tend to be really occur or get stuck in really or imprisoned in a certain way in the brain, separate from the adaptive memory, the normal memory that we have. And that really help the patient, the client, not only understand the process, but also resonate with the experience, because they often feel they are in prison, they are restricted by the trauma, and help to reduce the sense of shame. And what EMDR does is link, as you have experienced in the exercises, link this memory, the traumatic memory, that is separate and that is locked away from the adaptive memory, link it to the adaptive memory. And that is really according to Shapiro, according to the adaptive information processing theory, is really the therapeutic process in EMDR. Okay. In complex patients, in addition to dissociation that Caroline described, there are other problems. I mean, just because a lot of you work probably with patients with borderline personality disorder. If you remember borderline personality disorder patients, they are typical of complex trauma patients. And actually, Van der Kolk, in a study, famous study, discovered that 90% of borderline personality patients have complex trauma in the background, childhood, earlier times. So as you know, these patients have always risk to themselves, and most likely to themselves because they self-harm or sometimes have suicidal attempts, or sometimes even aggression and anger towards others. They often have problems with environmental safety because of their impulsivity, self-harm, other impulsive actions they take, like Caroline was talking about crossing the streets in Alexandria, can be, for us can be an impulsive. A lot of people here do it smart and but so it feels very unsafe for us being used to going through sort of traffic lights and things like that. Usually they are quite socially isolated, so social support is a big issue for these patients with complex trauma. In addition to, as we discussed, or as Caroline discussed in the ACE study, which really again highlight issues about complex trauma, physical health can be a big problem in addition to the psychological problem that we spoke about. And we need to address that in our preparation. Neurological impairment and epilepsy can be a big problem, trauma and complex trauma. And hence we need to be in liaison with physician specialists who deal with these issues, making sure that the patients are well controlled, well treated, because there is evidence that really if the patient is not well controlled, eye movement can trigger epileptic fits. So we need to make sure that we can check with the specialist that this is the case, they are well controlled, whether it is epilepsy, heart problems, any other physical problem they are suffering from. Drug and alcohol abuse is a common problem in complex trauma. And actually, according to the ACE study, the strongest statistical association that ever were found between heroin addiction with any other factor was with the ACEs, the number of ACEs. Again, it is well described in the Van der Kolk book. Of course, they get into a lot of legal issues and problems with the law, and that can be, again, an issue that we need to address in the preparation and the treatment plan. Because of this chaotic lifestyle, we need also take in consideration the timing of the therapy. I mean, somebody who is homeless, I work with sort of services for homeless people in London. It's very difficult to do any form of therapy when people are going back to the streets. So we need to take in consideration what is good. Often these people have issues of grief, life event. We spoke about dissociative disorder. We'll speak about it in a minute. There is the impulse control issues with complex trauma that can be a big problem. So that's all these made it very important for us to spend adequate time to prepare the patient for processing. And I mean, with single trauma, probably you could do, and I have done that, the history and preparation in one session, 90-minute session. But with complex trauma, you might take 4 or 5 sessions just preparing the patient for processing. And we'll talk about what you need to use in these circumstances. As we spoke earlier, the main issue will be to keep, because therapy will not work if people are either hyper-aroused and unable to tolerate the therapy, or they are hypo-aroused and not there with you. And dissociation is really also a form of hypo-arousal. So it is very important that we keep, and one aim of the preparation process is to keep the client within the window of tolerance. And as we said before, it is really a balance in the autonomic nervous system between the sympathetic nervous system, which usually causes hyperarousal, excretion of the stress hormones, adrenaline and cortisol, while the hypoarousal is caused by the parasympathetic system. And what we need is the balance between the two. I showed you this example of hyperarousal in the cinema. Somebody got scared by a horror film, or hypoarousal parasympathetic system. So remember, sympathetic, parasympathetic system in a film theater. We discussed that what we can use to help patients in general trauma, but more importantly, complex trauma. What relaxation techniques do you use, or are you used to using in your practice?
Progressive muscular relaxation.
Any other exercise? Physical exercise can be helpful. We'll talk about this in a minute.
Guided relaxation exercises and guided meditation.
Guided meditation can be part of mindfulness, being in the moment, and that helps also not only in sort of relaxation, but also in the grounding.
Music, playing games, dancing.
And because a lot of our complex trauma clients have physical problems in addition to some of them psychologically based, some of them are physically based, light stream technique is very helpful. We'll talk about it. We'll give you the protocol for that in a minute. Diaphragmatic, I think Dr. Tariq mentioned breathing exercises, and the idea of diaphragmatic breathing is that the diaphragmatic breathing normally triggers the parasympathetic system, so it helps to balance the autonomic nervous system and help people be in the window of tolerance. And as I said to you previously, children usually breathe diaphragmatically if you watch them. But we gradually, as we get traumatized by life, we start breathing from our chest and to also hide our bellies. But that is, of course, don't help when you are hyper-aroused. Safe, calm, peaceful place. I mean, we called it safe place before, but with complex trauma patient, it might not be appropriate to call it safe place because they probably never been saved. People who were brought up in a children home were abused there and went from one foster parent to another foster who were all abusive. Safe might not be an idea that will resonate with the positive images and situation that we want to take care of. So maybe calling it, a lot of people use special place rather than, or some people call it calm or peaceful place, but particularly for complex trauma patients, I would use a special place that doesn't have any value system to it, special to the patient, but not necessarily have the connotation of safety or calmness or peacefulness that they might not resonate, where there's history, where feelings might not resonate with. And there is the resource development and installation procedure that was described by Leeds in his book on EMDR. That's probably the second best after Francine Shapiro's book. We will discuss in a minute also that could be an alternative to a safe place. I mean, we asked you the question before, if patients could not do the safe place, could we go into processing? Especially in complex trauma, it is very important that they have a resort for self-soothing, and the alternative is the resort development installation step. Some people use light stream as an alternative also. Important also to encourage the patient to live healthily, and as described earlier, exercise does help people mentally, and there is a lot of research now on the effect of exercise on anxiety state, on depression state. It helps in different mood disorders. So it's very important to encourage patients to exercise as one of the resources, one of the preparation side of things. I'm not going to go through the safe place because it's a special place, but really want to discuss in details with you the light stream, because that is very helpful with patients in general, particularly if they have physical symptoms, but in complex trauma patients, clients and patients in general. So I want really to do an exercise on that. So I'm going to ask you, forget what is on there, this is not related to it, by the way. I'll distribute the slide in a minute, sorry, the protocol in a minute after we finish. I want you all to close your eyes. Try to think of anybody anywhere in your body that have any tension or pain. A lot of us have maybe pains and aches somewhere because we were, sorry?
Is part of the body, or you could have more than one place?
Sorry, I'm not hearing.
Only one part or more than one part?
You have to focus on just one part.
At this stage, one part, just for the sake of the exercise, but you will see during the exercise, the aim also is to calm and soothe the whole body. But maybe you could ask the question after we finish, and we can discuss it further. But so I want you all to think of any distress. Maybe you walked a lot yesterday and have some pain in the legs or in the back or whatever. And if you close your eyes, okay, and I want you, every one of you, to think, what is my the preferred calming color? Everybody have their own preferred color. Mine is green. Some people have pink. Some people have blue color. I think probably Alexandrian people might be biased toward the blue, the sea blue. So if you choose the color that is the most relaxing for you, and then imagine, so please close your eyes, and imagine a light coming from the sky, from heaven, okay? And that color, in that relaxing, preferred color that you like, coming from the sky and entering your body from your head. The light is coming in gradually, filling all your body and going through your head, your chest, your arms, belly, legs, flowing around and making you relax in all these parts of your body. Try to experience this relaxing color going through different parts of your body, making them relax, going through the muscles, the bones, making you feel relaxed, calm. And now, try to think about that part that hurts you, whether it is in the back or in the leg, and try to move and concentrate some of this light with your preferred color and concentrate, focus it on that area that hurts you or the area of tension in your body. Keep that light, relaxing light, focusing on that tension or pain for a minute, for a second, for a few seconds. Now open your eyes, take a deep breath, as we do when we start when we finish the processing. How did you feel? It's quite effective. Many of my patients found it quite helpful, particularly if they have pains and aches. I worked with a patient who had severe neurological damage in the neck after he was assaulted. So he not only suffered PTSD as a result of the assault, after he was a lorry driver in London, so there was what they call road rage, as happens in many roads in big towns and cities. And he was assaulted severely, that his neck was broken, but also he suffered severe PTSD. And he found light stream a very helpful exercise to help soothe the pain. That didn't stop it because there is a neurological base to it, but it helps soothe that pain. I can see some people sleeping, which is great because that seems it is effective. So, right. Now we will move to the resource development and installation, RDI, and it is really, has been used, I must tell you. I mean, we spoke about the fact that sometimes we only can see somebody once or for a very short period. And in situation like this, it might be a good idea to use this technique because you can then gear it to the problem of the person. And so you can use it either as a problem-directed resource. So for example, if somebody has phobia, we say to them, what is the character, the quality that you need to overcome this problem? And maybe they say, I need courage, or I need to be stronger. So then we will try to find in their history, in their relationship, or even sometimes in imaginary resources, what can represent that quality, that thing that they need. Okay? We use this in vulnerable and complex patients, as we said, to enhance the ability to cope and process. And sometimes we use it as an alternative to the safe place or special place in cases patients couldn't really find a safe place, couldn't install a safe place. And there are, as I said earlier, of 3 types. Mastery memories, for example. Are there any times in your life when you had this character strength? For example, say, yes, when I was in the army, for example. Or that might not be always a good example, but some patients said that when I was in the army, I felt strength. Or when I graduated from the college and I was awarded the first set of my class or whatever. So this is really an any particular time in which they showed distinction, mastery, that can, particularly if it is related to the problem that they want to overcome. If that is not there, then what we call relational resources, i.e., do you know anybody who have this character? A friend, an uncle, a relative, a brother, anybody who have these characters that you can use as a resource. So Uncle Muhammad, for example, have this character, and Uncle Muhammad become a resource for us that could overcome the problem that we are suffering from. Okay. So really, after identifying this...
And the third one was symbols?
Sorry?
And the third one was symbols?
The what?
The third one.
Yes. And the third one is the symbolic or imaginary. I apologize for that, yes. Or imaginary. Like, for example, you can say people from history, like Hunter ibn Shaddad, for example, as a symbol we have of courage and strength, or hero of some description. Or some people in the West use Superman, for example, as a symbol or a sorry. Yes, even adults, yes. Or some in a film, as Dr. Khalid said, using a character in a film you have seen, in a book you have read. All these are more symbolic, imaginary character that can be used. So really the criteria is to identify what is the problem. As I said, this is when you use it on its own. You can use it in two ways. If you don't have time to do the whole protocol, then and you have only one session with the patient, this is a very good thing to do. There is evidence, research coming particularly from Southeast Asia, so it is very helpful to trauma victims, to resource them with the RDI. So, as we said earlier, what is the problem? What quality you need to overcome this problem? And then you find the person or the symbol that represent this character, this quality that the patients need, and it associated with positive effect. If it is an ankle that used to hit the person in childhood, it won't be a good really resource, of course. So you need to be careful about that. So it has not only to represent the quality needed, but also the capacity needed, but also it has to be a positive effect, associated with positive effect. Then you need, as you do with the safe place, you need to access this memory, remember that person, for example, in their most powerful state. If you are looking about power and strength. Well, can you remember Uncle Muhammad in his most powerful strength, strong status, and describe to me, like you do with the safe place, how did he look, how did he sound, how did you feel yourself when you saw him in this character, like you do when you are in a safe place, in a similar way.
This is before working on grief, about losing that person, or
well, this is what I was saying. If the person is dead recently and there is still a grief issue, then probably it won't be a good idea to use that. But if the uncle is still there and still supportive, and still have a very good relationship with the person, then it will have the positive effect that needed. So it has to be really a positive symbol, positive relation, positive period of the person's life to be used as a resource in this case. So yeah, I agree with you. We need to be careful about it. Believe that
they're actually using a face and not a person, because if processing, it turns out that this person has done something or something, and then you have to
well, that's always a risk. I think I told you about this client of mine who chose this wonderful safe place in the she shelter, forgot to tell me that his wife was stopping him from seeing his young daughter. It was there with him in the supposedly safe place, but he remembered later, and of course that means the safe place is no longer, it's not safe. We need to change it. So this can happen in therapy. Of course, good history might help us not to go into that mistake, but sometimes patients forget, unfortunately, and then you remember later the processing So that is really what, as we then try to strengthen that resource in the same way we do it with a safe place with short, slow movements, 6 to 12 movement here in Leeds protocol, either eye movement of taps or tones, and we can really repeat like we do in the safe place, we repeat the description of the patient of that resource. Of Uncle Muhammad in his most strong status, how did he look, how did he sound, what did you feel, and we read that back while we are installing that resource. Okay? And actually, there is no, I personally do testing like I do with the safe place, special place, but here it's not really just trying to install that resource and have feedback from the patient. And imagine being, for example, that resource with the fear or phobia or the situation, the problem that we are trying to deal with. And by the patient repeating that afterwards, as I said, this is very helpful tool if you are seeing the patients one. Continue to use it, that will help to reduce the anxiety, phobia, panic attacks or whatever. As was found in Southeast Asia, the studies they did that. But you can use it in the same way like the safe place also, by installing it and use it, either asking the patient to use it when they feel the stress, or use it to end the session, as we do with the safe place, in the same manner as we do with the safe or special place. Any question on this?
As I understand, if it's an interpersonal resource,
Yeah.
so you bring the who has the qualities that I need for managing my situation.
To overcome the problem.
And then I
Yeah.
like
Maybe
that.
you can-
It's like I imagine an image for me with that person or what? Do I install it like a still image like what I do? And then how can I convert it into an image with installation? Is it only the person or me inside a scene with the person?
Not necessarily, no, not you, just that person. But of course, you also have to see now, when I said your body sensation now, not when the person has now. Like you do with the safe place. Describe how you feel, the body sensation, describe the strength or the incidence of strength that this person or this episode of your life or this symbol represent in details of what you see, what you hear, what you smell, what you feel in your body, and so on and so forth, and try to install it. Okay, any other question about this? Because that's really very important, so especially in complex trauma. So let's go into the methods related to, we spoke about dissociation, and there is very important book. Jim Knight is an American EMDR therapist, and he has this book, EMDR Toolbox. And anybody who works with complex trauma, it is a very helpful book for dealing with complex trauma. In addition to the dissociative experiences scale, that we spoke about, and I'll send it to Usama, inshallah, and he will send it to you all. There is also something clinical tool that's called the back of the head scale that Jim Knight invented. It's very helpful to use during the session. This scale you can give to the patient to fill after the first assessment, or sometimes people send it to the patient before first session. And I remember it was given to us in the part 1, and we were said if this sort of the score of the deaths is more than 30%, try to refer the patient to a more experienced EMDR therapist, because this indicates a more significant dissociative experiences. But during the session, there is this back of the head scale, and I'm going to describe it to you. It is a scale, an imaginary scale that you can use with the patient and use it during the session. A scale that describes the distance between the back of the head, this is where my right hand is now, and however stretched. I mean, I think Jim Knight said 10-inch from, but it is easier just to say where your hand can go, okay? And you say to the patient, you are not here in the room at all, okay? So you are completely dissociated in the back of the head, while this is you are here in the room 100%. You are grounded, you are not dissociated at all. And you need the patient to score where they are in the room with you, from being completely dissociated at the back of the head to being completely with you and no dissociation whatsoever. And Jim Knight says you need to be at least in the middle between this point and the face, beyond half the point for the reprocessing to work, for the therapy to work, okay? And if they are not in that less dissociative, more effective therapy, we need to ground them. Okay, so what is the most simple grounding technique we can use? You know? That's right.
Getting out up and
Getting out, walking, but this is the simple.
not out.
Yeah, but really
And
the video.
sometimes jumping.
I think it's a good idea to see there is a YouTube video of Jim Knight doing the back, the scale, and the grounding. And you can see how the patients came back after sort of throwing so like I'm doing with you, Doctor. What is your name, Dr. Ahmed? So try to catch this. Broken.
In the back of his.
Sorry? He went back after his Yes, then you ask them, where are you now? Scale. Back of the head scale. And you can see a change. If the person is not enough, I mean, for example, in DID, dissociative identity disorder, which is very severe form of dissociation, as Caroline described earlier, you might need to use more elaborate and complex technique, which is called the constant installation of positive orientation and safety, or really summarized as CPOS. Okay, CPOS. And that's, again, there is another YouTube video on that you can watch on YouTube to understand how to do this. It's a bit of complex course, but describing it easily is that the patient or the client go to the trauma memory and go back. So it's like an exercise of really bringing the patient, grounding them back to the session in the treatment room. So they go back to the, then you count from 5 to 0, and of course teaching them that, and they wake up at the count of 0, and you ask them then to move their hands, move their neck, feel the chair in the back, feel the chair on the legs, stand there, they're going to go around and try to see 3 things you haven't seen in the room before, try to hear 3 sounds you haven't heard before, and that helped the patient to be grounded and be back to the therapy. I used to use this every 15 minutes with a patient who was severely dissociated. Every 15 minutes in the session, I can see how, but that was the only way to keep him present and able to benefit from the therapy. So, container exercise, very important also in complex trauma, because these people have so many traumas that it is helpful to keep some of the, so there might be 2 traumas of the same strength, and they want to work on them together. And it's helpful to keep one of these traumas in a container. And I described to you last time the envelope container exercise that I found very helpful, particularly with complex trauma. They draw a symbol of the trauma, and we keep it in an envelope, and I give them usually a stapler and ask them to staple it and keep it in their file. So they feel it is left with me and we can deal with it at some point. It helps them to be able to postpone that issue while working on therapeutically more important issues, or maybe a touchstone in some cases. So that is also helpful in that case, the container exercise. There is also another very helpful resource called, it is the resource for what's called attachment focus EMDR. And again, there is a book. I haven't brought a picture of the book of Laurel Arnell, an American psychologist who works mainly on this form of EMDR therapy. And as you know, a lot of these complex trauma clients, they haven't had figures in their life, attachment figure, important attachment figure. And she helped the client in their the resources she called tapping in. And there is a video, by the way. If you look for tapping in, you will find a video on how you resource or install these resources. And there are 3 types of resources. Nurturing figures. Normally, the most important nurturing figure in life is the mother, of course. But for somebody who was abused by his parents, neglected, kicked out, or of course that is, the mother is not a nurturing figure. It can be with some patients with complex trauma. The mother cannot be a nurturing figure for historical reason of some description, which is common in complex trauma clients. So what we do is, again, like we did with the RDI, the resource development and installation, we find either a figure from a person's life, like for example, the mother was not a nurturing figure, the teacher might be, or the auntie or the grandmother might be a nurturing figure. And installing that resource can be very helpful. And really, in Arnell's book, you need 3 nurturing figures and 3 protective figures. Again, the stereotype is the father is in childhood, the father is the protective figure. But some fathers who are abusive or absent or neglectful cannot be an attachment figure in a protective way. So again, you use either somebody from your life or imaginary, for both situations, either a real person or an imaginary person. Somebody you saw in a film that represent to you nurturing or protection or wisdom. We'll talk about wisdom. Or somebody you read, or somebody you read about in a book, in a novel, or somebody from history, I mean, religious figures, or that can represent nurturing or protection figure. Sorry, you have a question.
Yeah, I'm asking if the
So
client.
just a moment.
Yes. If the client chose me as a therapist to represent one of these figures.
Very, 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 very good question. Thank you very much. Very, very common issue. I would say we can use the therapist or the doctor as a resource, but as a last resort. I would say you can find another person because you are there with them in the room. And it might be better if we can use other figures, whether they are real or imaginary.
But it's
But
not.
of course, if we don't find another figure, or the patient insists that yes, I have used, I have been given a figure from description in this form of therapy. Sorry, you want to ask a question? No, not you, sorry. And the last figure is so the inner wisdom figure. Somebody who was guiding light in your life. A teacher, a clergyman, a religious person, or again, somebody who read their books and influenced by their thinking, professor in the university with whom you identified as a wisdom figure who helped you not only to teach you the material but also guided you through your life. And again, you need three. So according to Parnell, you need three of each of these figures. And again, you install them in the same way we installed the safe place or the RDI. And then we bring them all in our safe place. And we imagine what Parnell calls the circle of inner helpers. So you in the safe place with 9 of these figures, 3 nurturing figures, 3 protection figures, and 3 inner wisdom figures. And it can be quite a powerful tool for patients with complex trauma. Because that is the main problem is attachment problems in their case, issues about their childhood being mistreated. So using real or imagined figures, attachment figure can be very, and installing them and using them can be a very powerful tool in such complex cases. I think there was
Excuse me.
sorry, yes.
Are we installing each figure or we install them as a group?
Each figure is installed in the same way we did with the RDI. You remember that in the most nurturing stand or situation. How did they look? What did you hear? How did they sound? How did you feel in your body when? And then you install all this.
We install everyone in the safe place?
No, you install them separately. Then in the end, you gather them all and install the circle of inner helpers. So you have many stages of, you have 10 installations to do, but it is very effective. It's worth it really to go through this process. It takes time. Sorry, it takes time.
If later during processing,
Yes.
One of these figures was linked to the trauma,
Yeah,
what would you do?
Yeah, so the question is, if later in the processing we discover that actually one of these figures are abusive or related to the trauma, as Dr. Osama said, what would we do? It's the same situation if you discover that the safe place is not appropriate because the patient remembers that something happened there or trauma. You can replace the figure with another more appropriate figure. Sorry.
Installation by slow hand movement?
Yes, the same way. Parnell used more tapping and she used it in a different way. I'll show you. Can I? She used tapping in this way. And some people find it quite effective,
What is
really.
the difference? What does it intend to do?
I mean, it doesn't, but some people, it is another choice. I'm just giving it to you as another choice of type of tattoo. I mean, she's using that form of tapping. She also used tappers. She put it under the thigh, under the thigh. And so this a variation of bilateral stimulation. Just to mention, because you might watch her, again, there are videos that you can watch her on YouTube and get more explanation on that. I think I did discuss that yoga, and as Van der Kolk, he mostly emphasized neurofeedback, and theater can be added to EMDR to enrich the person, be able and enrich the therapeutic process. And as I said, there is a paper on using Sufi dhikr as a way of also resourcing the patient. Can send it to you through Dr. Tusama, inshallah. So, in conclusion, preparation is a very important stage in EMDR therapy in general, but even more important in complex trauma, because we need to do more of that for a longer period of time for the patient or client to be able to withstand and be able to go through the processing, the EMDR processing. So that will ensure the stability and resourcing of the clients in going through the therapy. We described the different kind of methods, but as we said in previous sessions, we can use other methods from other therapies. If you find anything you used before as a helpful resource from other form of therapy, no harm in using it as a resource, especially in complex trauma, because you really need to resource the patient as much as you can for them to be able to go through the therapy effectively, for them to benefit from it. We discussed the different methods, and if there are any other questions, please don't hesitate. Yes.
I just want to ask if there's any special recommendation or
Just a
things.
moment. Go on.
I just want to ask about any special recommendation for people who they are still having abuse and the abuser is still there. They are continuous abuse, and also the people who they don't have the basic needs like safety and so like people in the camp.
Yes, thank you very much. Very important question. The question is, if the abuse is continuing, the trauma is continuing, and the patient or the client is still in a situation where they are being abused or traumatized continuously, what would we do? As we said earlier in previous lecture, it's very important for the client not only to feel safe during the session, but also to be safe. I mean, I gave the example of homeless people who go and sleep in the street. Of course, in this case, therapy will hardly work. Of course, we sometimes do try. I think we have example of Dr. Khalid here who works with refugees in camps and different situations. He tries his best to help them, but they are not in an ideal situation. But then we have to do that. But in a situation, a peaceful situation like here, it's very important as part of the preparation is to ensure that the person is out of the abuse, traumatic situation, and liaising with social services to get people into refuge or involve the police to get to stop the abuse will be part of our preparation of the patient.
In worst scenario, we cannot help them to have safe place or something. What we could do, just try to them
In what, sorry, what?
I mean, if we couldn't provide them a safe place, or we couldn't get them away from the abuser or something, and what we can do, what I can do as a therapist for them, I just have to try with them like this.
If we can't get them out of the, is that your question? If we cannot get the person out of the abusive situation,
So
can we still work with them
Yes.
or not? Is that your question?
Yes,
Am I
exactly.
correct
Yes.
in that? Yeah. Yes, we can work, we can, but the question here is how effective it will be if the trauma is continuing. Of course, as I said, the resourcing is very important because it might help cushion or reduce the pathological effect of the trauma. But ideally, we need, as part of the preparation for the therapy, to get them out of the situation. But I agree with you, I mean, in the same situation as we spoke about refugees, for example, in a very difficult situation, whether it is these tents that are full with water and many families living in the same house, and sometimes abuse goes on there, and Dr. Khalid and other EMDR worker go there and try their best to help these patients. But as I said, in a normal, peaceful situation, I will also work to try to get the patient safe out of the abusive situation. So,
I wonder about your question if it is ethical
yeah.
point of view
Yes.
to help our clients to tolerate through any kind of therapy and to maintain in an
Yeah.
abusive situation,
Yes.
because our target is to let them
Of course.
So
Yeah.
I think what you are asking is very much an ethical dilemma.
Yeah.
So if what I'm going to help in, what is my goal, what is my target? So it is rather very ethical.
It is very ethical situation, and that's why I started with saying it is very important to make the patient safe. Not only our aim is to get them out of the situation, whether through the police, social services, or any other means. But in a situation like refugees in a camp where they are flooded and there is abuse going on there, and you cannot do much about this, what will you do?
So,
Will you help or not help? This is
I recall somebody describing that situation, and they said that so somebody was sexually assaulted, they were in a refugee camp, they'd been sexually assaulted in their country previously, they'd been sexually assaulted in the refugee camp, and they were staying in the refugee camp. And to be honest, the situation wasn't likely to change, there was a risk. So before they began the processing, part of the preparation phase was to install resources on how you can keep yourself safe now. So we'll always walk around in twos. I will not go there, I will avoid this, I won't go out after this time. So there was resources in how you can keep yourself safe in this environment now, and then they could then process the trauma memories, so their clients' arousal levels were low, which lower. They had an element of hyperarousal that they were going to keep that was natural and understandable for their environment. And I think it's not really a one-size-fits-all question. We have to look at what's happening for the client, what do we need to be able to do. I remember the previous trainer I worked with, she presented a case where the wife was in a domestic violence situation with her husband, and the wife had no intention to leave. You could work as much as you wanted to on leaving, she was not going to leave that marriage. So the very beginning part of the preparation was very much resourcing her, helping her understand her choices, helping her understand why she made those choices, and then they were able to process some of the memories which actually led to her making different choices within her relationship. But it's not a one-size-fits-all, so we have to think about what you've got available to you, about the client's resources, about your timing, and all those factors.
Thank you very much. And as Caroline said, psychoeducation is, again, we haven't covered fully, but psychoeducation includes all these things in terms of what is your rights in related to the situation they are in.
I'm just asking one thing. If technique like what you told us yesterday about the phobias, about the future destination, could help to change in the resources and changing how can I behave to protect myself in the future or something like
So using the flash forward to process
yeah.
how I could cope with this situation in the future. I think it's a really good idea. Yeah.
Suggestion be,
Yeah.
yes.
And get stronger.
That's
actually
one
very
word we need to finish.
Yes, thank you very much. Thanks.
Thank you, Dr. Ravi. I want to show you your last slide. Here. This was your last slide, wasn't it? Tension is who you think you should be. Relaxation is who you are.
This is a Chinese proverb. I think a lot of patient complex trauma clients, they think that tension is a normal part of them. And maybe teaching them something like that help, maybe as an interview, to help them change their mind about this.
And for the final slide, he had keep calm and stay cool, which I think is a hilarious major. Stay cool with air conditioning. Thank you very much. Now, okay, so I was going to show you a video on complex trauma, but I'm thinking not to do that now. And I'm just wondering, and I definitely don't want to sound inappropriate, please turn that off.